We'd now like to welcome Dr. Donal McLornan, who's going to give us the updates from the European Hematological Association research. Thank you, Donal.
So welcome everyone. This morning I'm going to bring us through some of the relevant abstracts and presentations from EHA, which for this year was virtual. Really what I want to focus on over the next few minutes is some updated data from the interim analysis of Rho-PEG interferon. So that's pegylated interferon, that's from AOP Pharma. As regards myelofibrosis, I want to focus on the concept of Ruxolitinib discontinuation syndrome. And I want to provide some updates from clinical trials, such as the MANIFEST study and KRT 232. So if we focus on polycythemia vera, there was an update from Professor Baubui about a phase 2 randomized clinical trial that was comparing Rho-PEG interferon versus phlebotomy, i.e. venesection, in low-risk patients with PV. So this was the pre-planned interim analysis of the low PV trial. So this is a phase 2 study, and as we're all aware, for patients less than the age of 60 with polycythemia vera and no history of thrombosis who are defined as low risk, phlebotomy alone is considered the standard of care. However, for us within the MPN community, it is still unclear whether phlebotomy alone is enough to maintain the hematocrit below 45% over time. And we know that if it rises above that significantly and is unaddressed, there is a higher risk of cardiovascular or thrombotic complications. So an unanswered question is, does the addition of additional cytoreductive therapy, such as Rho-PEG interferon, lead to more robust outcomes within patients with PV who are defined as low risk? And to try to address some of these questions, there was the design of a phase 2 study that plans to enroll a total of 150 patients with polycythemia vera who are determined as low risk. And just to recap, that's less than the age of 60 with no history of cardiovascular or thrombotic complications. This interim analysis was randomized patients 1-to-1, so there are 50 patients in both arms. When the trial completes, there will be 75 patients in both arms, and randomized patients between phlebotomy and aspirin versus phlebotomy and aspirin with the addition of Rho-PEG interferon. The primary endpoint of the trial was to assess the proportion of responders at the 1 year mark. And by responders for the primary endpoint, we mean where the median hematocrit is maintained less than 45% and with the absence of disease progression. In the second year of the study, and this is the switch extension phase, for patients on phlebotomy and aspirin who are responding and meet the primary endpoint, they can continue in the same arm. But if they're not responding, they can switch to the same cohort as phlebotomy and aspirin, but with the addition of Rho-PEG interferon. So when we look at the initial interim analysis, and it's important to stress that this is an interim analysis, we can see that for the primary endpoint, so again, maintaining hematocrit below 45% and no evidence of disease progression, this favoured the cohort which is shown in the red bar. 84% of patients within that cohort met that primary endpoint versus only 60% in the standard of care, which is phlebotomy and aspirin. When we look at hematocrit control, we additionally see that more patients in the Rho-PEG interferon arm achieved the hematocrit control endpoint. Importantly to note, for patients, the numbers of phlebotomies required was significantly lower in those patients who were receiving Rho-PEG interferon versus the standard phlebotomy arm. We know that with PV there can be a large number or a small number or non-existent symptoms, so it's a very heterogeneous disorder as regards which symptoms patients may experience. Importantly, for those patients who were treated with Rho-PEG interferon 2-beta, overall there was a 21% reduction in symptoms that are classically associated with PV. And of interest, you can see here that there was the downward facing bars show a reduction in symptoms versus the upward facing, which show over time an increase in symptoms. And here we can see on the left side that there's reduction in symptoms such as night sweats and most importantly itching, whereas in the standard arm this was not seen across the board. So certainly as regards symptom improvement and control, this favoured the addition of rho-peg interferon. So this interim analysis fully demonstrates that rho-peg interferon in low-risk PV is more efficacious in keeping the hematocrit at target levels in comparison to a strict and rigorous phlebotomy policy only. Importantly, in addition to better hematocrit target control, patients presented with a reduction in the numbers of phlebotomy required and a better quality of life, but this requires longer follow-up, and secondary endpoints such as changes in bone marrow pathology, quality of life measures, and overall numbers of phlebotomy required will be seen as the trial data matures. So next, switching to ruxolitinib discontinuation syndrome, there was a presentation by the Italian group by Francesca Palandri, which tries to define such a concept of ruxolitinib discontinuation syndrome, or RDS. This can be thought of as significant symptoms that occur following discontinuation of ruxolitinib, usually manifested as a marked rebound in splenomegaly, plus or minus a rebound in symptoms. This can commonly be occurring within the first 3 weeks following discontinuation of ruxolitinib, and it happens due to a massive release of inflammatory cytokines, which can drive the spleen progression and also drive the symptoms. And this is a very important consideration when we're switching between therapies, consideration for stopping or tapering down ruxolitinib prior to clinical trials, and also for when we're stopping or tapering ruxolitinib prior to transplantation. So there were 251 patients treated with ruxolitinib, and overall ruxolitinib discontinuation syndrome was observed in 13.5%. It's important to stress that the vast majority had either mild or moderate ruxolitinib discontinuation syndrome, and almost 87% of patients did not. So although it can occur, it is a more unusual occurrence, but it is very important to be aware. For those patients who had mild or moderate RDS, this was predominantly a symptomatic increase in spleen, and there could have been also symptom rebound. For mild RDS, 14% of patients required reintroduction of JAK inhibitor, and this was 30% for those with moderate RDS. When we think about the timing of the events, for mild or moderate RDS, this commonly occurs within 7 to 10 days, but it was usually much quicker, happening within 48 hours for those with severe RDS. And part of it reflects not only the disease stage and how inflammatory the disease is at the time of discontinuation, but also how the ruxolitinib is handled and whether it's stopped abruptly or it's tapered correctly prior to switching therapy or moving on with other treatment modalities. There are a host of agents that are currently in either early or late stage clinical trials, and here we can see some of the overall concepts, whether they're agents that are acting as monotherapy, so single agents, or agents that are in combination commonly with ruxolitinib. And really the focus of the clinical trials for myelofibrosis has either been upfront treatment, often of new drugs in combination with JAK inhibitor, or how we manage patients who've potentially been treated with ruxolitinib and unfortunately have been intolerant or lost their response to ruxolitinib. One of the interesting compounds that some of us in the audience will have had familiarity with that's been open across the UK is KRT232. So this is an oral MDM2 inhibitor. So this is a potent selective inhibitor of MDM2, and it offers the potential to deliver disease-modifying effects by ultimately affecting the MPN stem and progenitor cells. We know that MDM2 is overexpressed, particularly in patients with myelofibrosis, but also in patients with polycythemia vera, when we compare it to individuals who do not have an MPN. The MPN-associated driver mutations can lead to upregulation indirectly of MDM2, and that affects a protein which is known as P53. And if there's abrogation of the normal function of P53, that ultimately propagates proliferation, which is a hallmark feature of MPN. The KR2T232 trial initially had 3 cohorts and then extended to 4 and looked at differing dosages of the agent commonly given for 1 to 7 days over either a 21 or 28 day period to find the safest and most efficacious dosing schedule. And like most trials in myelofibrosis, we were looking at spleen and symptom responses. Here we can see the 240 milligram dose on a 28-day dose schedule. And we're seeing that when we look at this spleen volume reduction and we're targeting by imaging at least 35% reduction from baseline spleen size, we can see this is reached in around 16% of patients. And in this trial, these patients had previously failed Ruxolitinib. And as regards symptom control, we're seeing around 30% of patients get a 50% reduction in the baseline symptoms. So this is an interesting compound. It's the first clinical proof of concept study highlighting the important role of MDM inhibition. And there will be a phase 3 trial that will be rolled out across certain European centres. Next, we have the Manifest study. This is a BET inhibitor, so CPI-0610 is what's called a BET inhibitor. So BET proteins have multiple functions, and BET proteins act as readers within the epigenome. And that's involved in MPN maintenance and also inflammation. And when we inhibit these BET proteins, what we're trying to do is to establish more normal hematopoiesis or blood cell production. You can see that in the MPN setting, the BET proteins are involved in driving pro-inflammatory cytokines, and also they drive the blood cell factory production towards more megakaryocytes, so platelet-making cell production, which behave abnormally, drive inflammation, and indirectly drive fibrosis. In the Manifest study, this was quite a complex phase 2 study with multiple arms, but really what we're looking at in patients who had previously been exposed to Ruxolitinib but were no longer taking it, CPI-0610 alone. We were looking at patients who were still on Ruxolitinib and adding in CPI-0610, and then looking at the combination of CPI-0610 and Ruxolitinib for patients with myelofibrosis who had not been previously treated. The endpoints that the team were interested in were spleen and symptom responses, and also if patients were requiring transfusion, could we make them transfusion independent? Here we can see that we're seeing, if we think about arm 3, we're seeing improvements in spleen volume, we're seeing improvements in symptom scores. For a proportion of patients with anemia, we're seeing improvements in hemoglobin, and for some patients, we're seeing that if they were transfusion dependent, they can become transfusion independent. If you focus on the central slide, looking at the bone marrow pathology, in some responding patients, we're seeing establishment of more normal architecture within the bone marrow, and also a reduction in fibrosis. So not only are we seeing spleen and symptom improvements, but we're potentially also seeing disease modifications. There's a lot of detail on this slide, and I will summarize it in the next slide, and you will have these slides available. But really it tells us the percentage of patients who are getting spleen responses, because if we look at arm 3, for example, and that's patients who've never been treated with Ruxolitinib before, we're seeing that in 51 evaluable patients, when they were given the combination, 73% of patients achieved at least a 35% reduction in spleen volume size at 12 weeks, and there was a median spleen volume reduction of 51%. So in conclusion, it appears that CPI-0610 in combination with Ruxolitinib, or as a monotherapy, showed preliminary evidence of clinical activity and potential disease-modifying effects. We're seeing that it's generally well tolerated either alone or in combination with Ruxolitinib, and this will be proceeding to a phase 3 trial, which is eagerly awaited. An interesting compound to look out for is parsaclisib, which is a PI3K delta inhibitor. And again, there was a poster presentation at EHA this year focusing on patients who've had a suboptimal response to Ruxolitinib, and 53 patients were treated. There was dose alteration as regards safety and as regards scheduling, but again, we're seeing at an early interim analysis, we're seeing significant clinical spleen responses. So this is an interesting drug that hopefully we'll see more of in the future when it's used in combination with ruxolitinib.
Thank you, Donal, for giving us so much information about all the wonderful research that's being done. And now I'd like to welcome Professor Claire Harrison, who is going to talk to us about the UK research. Welcome, Claire.
Hello, I'm Claire Harrison, talking to you from Guy's and St Thomas's about current clinical trials in MPN. You've already heard a great presentation from Donal concerning current updates that were presented at the European Haematology Association, but we thought you might like to know what's currently happening about clinical trials in MPN. Well, I think the first thing to acknowledge is for the NHS at the present time, most non-COVID related research has been paused. We have been continuing to follow up patients in clinical trials and treat them, but in general the research teams have been busy and many of our staff have been redeployed. You've heard from Adam about current research, and really the UK is, I'm happy to say, leading the field with regard to this. But here's an example on this slide and the next one regarding what we've been doing at Guy's and St Thomas's. So, for example, we've redeployed 145 of our clinical trial research staff across the organisation, for example, into intensive care and other sites, and we've also set up a completely bespoke COVID research team. We've been recruiting patients across the entire spectrum of ages and clinical pathways, including, for example, maternity, studying the effect of the coronavirus on these patients. As of June, we'd recruited 1,748 patients into urgent public health studies and 2,460 participants into other local studies, for example, our own critical care database, a database looking at the effect of coronavirus on cancer patients, maternity, children's, for example. This is just another way of looking at the impact of the research portfolio for coronavirus just in the Guy's and St Thomas's organisation alone. We've been setting up clinical trials very quickly, on average 13 days. We've got 10 clinical trials ongoing, including the vaccine study, which is very, very exciting and very important. We've also been collecting data, and we've pooled a lot of our patient records so that we can learn about different aspects of coronavirus. For example, the Evelina Children's Hospital at St Thomas's described the new novel COVID-19 paediatric syndrome, so-called PMSTS. So it's no wonder that we've had to pause some of our activity, but don't worry, we are starting it back up again. So current status of UK MPN trials is that many of them are reopening, and in fact we've been opening studies quite rapidly at Guy's and St Thomas's, and different centres will open at different rates according to the capacity to see patients and the number of staff they have in their research team. We've always been very proud of our research trial portfolio, and rather than go through this in great detail, because you can see it on the MPN Voice website, just wanted to highlight that our research trials span the entire course of the disease and include, for example, the Mosaic study, about which Mary Frances McMullen has updated you, sample banks from which we've described mutations such as JAK2, calreticulin, and we have a new initiative known as eMPN, which is a pan-European database aiming for 5,000 patients opening. This year we will open 2 new ET studies, including some of the compounds you've heard about from Donal, in particular CPI-0610 and a different compound, IMG7289 or bomedemstat. Our PV studies, Mithridate, which is our frontline study supported by MPN Voice, is also opening again. And all the MF studies mentioned by Donal and more will be open and available for patients in the UK. We're also expecting some important results from trials this year. The results of Tamarin, a study in the UK looking at tamoxifen and its role in patients with MPN, will be reporting at ASH, as will the Phasar study looking at patients with an increasing number of blasts and leukemia. Donal also showed you data with regard to the MyMPN database, and with the MPN Research Foundation, we will continue to try to open this in the UK, but we have had some GDPR compliance issues so far. And just lastly, if you want to participate in research, I think there are some things that it's important to bear in mind. Providing data or samples can be just as important as drug studies. For example, all of the symptom tools that we've set up in collaboration with Ruben Messer and others, all of the samples that have been given that have allowed us to look at genomics and genomic classification of disease and prognosis. And if you're thinking of taking part in a drug study, remember, we usually test drugs to see if they are better, and some studies are randomized, so you may end up in the control arm. If you're thinking about taking part in a research study, you will be given a patient information sheet. Please read it carefully, look at the number of visits that are needed, and ask as many questions as you want. I look forward to joining you later for our panel discussion. Thank you.
Thank you, Claire, for your wonderful talk about the UK research agenda. We really look forward to having updates on these exciting projects.